Respected Chairperson, the audience, end of the day, and they have asked me to speak on recent management of painful diabetic neuropathy. I'm not going to give you pain because very few audiences left out, and I know the pain of staying in the hall throughout the day, but I will very quickly pass through the recent concept of management of diabetic painful peripheral neuropathy. Those who have confronted patients with peripheral neuropathy might be knowing that's not very easy to manage such cases, as it's quite frustrating. We do not have treatment and we prescribe one or the other medicine and it doesn't come out to the final solution. The prevalence is quite high. 10% of patients may present with peripheral neuropathy at time of presentation. 50% develop neuropathy within 5 to 10 years, and 60% of neuropathies are associated with pain throughout their life in patients with diabetes. The risk factors of painful diabetic neuropathy or neuropathy: the age, longer the age, more is the chance, duration of disease, glycemic variability, A1C, smoking and alcohol consumption. And this cartoon actually is suggesting that people with advanced age have increased chance of peripheral neuropathy, and also the complaint of painful peripheral neuropathy. The odd ratio for longer duration of diabetes is again very high, almost 6 times in patients who have diabetes less than 5 years than those who have diabetes of 15 years. So more chance of having peripheral neuropathy. Those who have more glycemic variability again have a high chance of peripheral neuropathy, and this has been shown in the slide that mean average of glucose excursion were quite high, on 5.8% in those who have peripheral neuropathy. Then those who didn't have peripheral neuropathy, the MAGE was 4.5 and it was statistically significant. So glycemic variability or glycemic excursion is again associated with increased chance of peripheral neuropathy. We know now the problem of peripheral neuropathy is quite common and it's quite frustrating. We do not have single drug available. We have a whole list of drugs acting centrally or some of them peripherally to relieve pain, but all of these medicines are not very efficacious, as we have already experienced in our clinic. Coming to the second part of the problem of peripheral neuropathy, we know that when there is a pain, there are two kinds of sensitization. One is a peripheral sensitization and another is a central sensitization. The peripheral sensitization means there is a liberation of the cytokines, which is an inflammatory sensitizing pool, and there is a quite large number of cytokines which are further accentuating the problem of pain. So there will be sensitization and pain increases in severity. This is followed by sensation of pain in the central region, that is in the thalamic region, and there is a kind of loop which perpetuates, and then it leads to a change in the perception of pain. And very simple example, you might have experienced that repeated pain leads to some kind of hyperalgesia or allodynia, that mere stimulus, any kind of stimulus give pain. So this kind of adaptation is taking place and we really do not know why it is happening. So when there is a persistent acute pain, it is followed by some remodeling of neuronal cytoarchitecture leading to a chronic pain, which leads to a different kind of perception, that is hyperalgesia, hyperesthesia or allodynia. So when this cartoon again is showing how it occurs when there is tissue injury, the COX-2 pathway, the prostacyclin pathway, again promoting the pain sensation, and there is acute pain. This is followed by change in the hair center, and that leads to a chronic pain. The chronic pain has a variable, as I said, that it may change the pain perception. This is a complex pathway. What is the importance here showing? That all these changes which are taking place are finally ending at this point, that is the liberation of calcium and cyclic AMP, and thereby changing the pain perception. So we have a whole plethora of changes occurring here, and they are finally consulting on one point, that is increasing the pain. if you look at these circles, there are some agents which have been tried. If they block the prostaglandin or they block the COX pathway, there might be some relief in the pain, and that has been tried. But if you are able to block this common thing, perhaps you will have more sustained response to pain amelioration. So, if you really want to prevent pain, you must target at the peripheral level as well as the central level. Now, this term neuroplasticity, this is just to explain what we are understanding in our mind, why this pain is occurring and how this pain perception is changing. The neuroplasticity means that there is some kind of dynamic change which are occurring in brain. But very age-old concept that brain doesn't change in adulthood. Whatever we have changed our brain is during infancy and early life or youth. But we don't get any change in the brain tissue in terms of any architectural change, or there is a functional improvement in adult life. That was the initial concept. And it was also considered that after the age, continuous neuron cell death occurs, atrophy of the mammalian brain begins, and hardly there is a chance of any improvement. So is the neuroscientific dogma of unchangeable human nervous system really true? If we answer that, then we can't do anything for pain relief. Whatever we do, it will be a temporary thing. But if we really want to change or curb the course of pain in our brain, curb the course of pain sensation, we can really do something. So let us change our concept of understanding, and that is the neuroplasticity. So what the experiments have shown, that there is a constant change in the nervous system in response to newer stimuli or some strong stimuli to the brain. And these constant changes can be measured or assessed. Results reveal that brain can adapt to compensate the disease and disability. So it is not a kind of fixed thing, it is a dynamic process, and that dynamism has actually made us to understand that we can do something for pain amelioration. This was a very simple study in which they took volunteers, 24 volunteers, and one group 12 were subjected to jugular activity or some skill activity. The other group didn't perform that jugular activity. And then they measured the brain anatomy by MRI and also the function. And what they found, that there was an increase in the gray matter of people who performed some skill work than those who didn't perform. And this kind of the anatomical changes which took place actually disappeared after both of them took rest and they were not involved in any kind of activity. It means that if there is a skillful activity, there will be some change in the brain, and that can also translate into function. So, human brain is incredibly adaptive. When one starts learning a skill over a period of time, it results into neural changes. This ability allows us to memorize new facts, master new skills, and form new memories. And that reminds that even if somebody wants to become a musician at very advanced age, it is now no bar. Means people can perform or can do some musical activity. So this ability of the neuron system to change the structure and connection is known as neuroplasticity. This was another experiment. When repeated stimuli was given to animal model, what they demonstrated, that there was a change in the pain threshold. The pain threshold rises, but then after a year of this repeated stimulus, the threshold became normal. And also the changes in the perception threshold actually was related to the time factor. Means with repeated stimulus over a time, there was a further increase in the pain threshold, but once the stimulus was removed, there was no change in the pain threshold. So this cartoon actually is again summarizing what I have said, that there is a peripheral activity in response to painful stimuli, and it is sent to brain, central sensitization, that leads to hyperalgesia, spontaneous pain, allodynia, and all these three attributes are actually due to decreased pain threshold because of the stimulus, enhanced expression of receptor at the central level, and increased spontaneous activity. So you feel the acute pain followed by the chronic pain, and the chronic pain persists with hyperalgesia, spontaneous pain and allodynia, and most of our diabetic patients actually are coming with this kind of problem. So if you have centrally acting drug, you can win over the problem of pain by reducing all these things, but the constant stimulus will persist. This is not given away, and the whole process can further be overcome after some time, and medicine may not work. So this was another good experiment. Volunteers who had pain, they were given lidocaine centrally by intravenous and topically nerve block. And what they demonstrated that after nerve block, the pain relief was highest in the group where it was applied topically than those who received systemic lidocaine. Systemic lidocaine has not done that benefit which was achievable by topical lidocaine application. So this experiment again proves what we have said, that it is better to hit the peripheral sensation than the central alone. And we have most of the drugs available which we are using in our clinics, like tramadol, gabapentin, pregabalin, amitriptyline, imipramine, which are basically acting at the central level. So we really need to do something for the peripheral sensation, and most of the randomized trials, RCTs, including the pregabalin or amitriptyline, have shown that these two drugs are equally effective, or sometimes one is superior over the other. Some of the papers have said that amitriptyline is far superior, others have said that pregabalin is non-inferior to amitriptyline. So limitation of these central acting drugs, that they work at the central level, and I said that they really do not address the problem of pain. The another, that on oral administration the concentration neural level is not achievable, which is always there if we apply it topically, and suboptimal doses will not work, and there will be some side effects which is always there with oral agents. And this has shown that pregabalin and amitriptyline are equal, and some of the paper have shown that amitriptyline is better. So mechanistically, gabapentin has been found to reduce release of neurotransmitter that are involved in nociceptive pain signaling, such as glutamate, calcitonin, gene-related peptide. These are the mediators of pain, and pregabalin acts through these mediators of pain. But the most important and specific effect of pregabalin is that it acts on the alpha to gamma subunit of L-type voltage-dependent calcium channel, and thereby it changes the glutamate response and ameliorates pain. If we use topically this agent, we should have certain characteristic of topical agent. It must penetrate and it must stay in the skin. So unless it is there, we cannot use a topical agent for treatment of peripheral neuropathy. Gabapentin featured for topical use. Gabapentin is highly hydrophilic and it can penetrate, and pharmacokinetics have suggested that application of gabapentin, it lasts for 6 hours. The first hour the concentration is achieved very high, that is 100, 180, even 400, but then 180 level is maintained throughout. So up to 6 hours the drug is retained in the skin. And this is the retention of the drug concentration shown in the skin, 28 to 29 in 6 hours. Results clearly indicate that high concentration of the applied dose gets accumulated in the skin, and the concentration maintained in the skin for a period of 6 hours. Subsequently, accumulation of gabapentin in skin blocks the neuronal generation of pain impulses from the peripheral neurons. This is also showing that the plasma concentration of gabapentin following topical application is 1/10 of what is achieved by oral administration. So we are achieving only 1/10 of systemic level of gabapentin, but same time the topical concentration is very high and that persists for 6 hours. So that is the advantage of topical application of gabapentin. The plasma concentration of gabapentin on topical application, as you can see here, that it was not that high, and it is devoid of all those side effects of the systemic administration of gabapentin. So advantage of topical gabapentin: inhibits peripheral sensitization, bypass the first pass metabolism, not metabolized in the liver, high concentration drug at site of injury, low systemic drug level, minimal adverse effect, no need to titrate dose, to tolerability and safe use of multiple mechanisms of action. So here, when we are using topical gabapentin, it will have more effect, and we can cut short the peripheral pain sensation or allodynia or hyperalgesia due to adaptation at the central level. So as I said, that mechanism, it is acting on the common pathway. Then these drugs like COX inhibitor or capsaicin, which is acting on the one component of the peripheral pain sensation. So I want to summarize this presentation that all components of neuropathic pain depends on inputs from peripheral nociceptors. Repetitive peripheral inputs leads to neuronal reorganization and persistence of pain, that is neuroplasticity mechanism. And blocking ongoing central sensation via peripheral interception will be more rewarding, and a fair role for old gold gabapentin, because gabapentin had stood to the test of topical application, showing effect and getting minimally absorbed. So one can use gabapentin at first start. However, there might be many more molecules which will actually act on the peripheral sensation and will give more benefit. But it is very easy to use, and it is not associated with any fear of side effects. I think we should try and give relief to our patients who are really having. We should buy time for them. Actually, we are not changing the whole pathophysiology, but buy time for them so that they pass off the agony of peripheral pain sensation. Thank you very much for your kind attention.